Hello, everyone, and thank you for joining me today for this discussion concerning the opioid crisis in America. I'm Dr. Paul Williams, and we at Pearson are dedicated to helping you who are working on the front lines with this crisis and providing you with tools for evidence-based treatment. We'd like to first start by thanking you for all your work and your passion with those that are hurting the community, because we at Pearson know that it takes great heart and a lot of passion to look into the faces such as these day in and day out and continue to help those that are hurting in your communities. And we thank you for that. Because this crisis is quite concerning and is killing and hurting a lot of families in our culture, in our communities around the United States. And when I see advertisements like this, it really drives the concern home that opioids are now the leading cause of death of people under 50. The rate of overdose for teenagers surged 20% in 2015 alone. And with a 10-day supply of opioid painkillers, 1 in 5 will become long-term users. Now, I know that at some point in my past, I have been one of these persons. But for the grace of God, it did not become an addiction. But for far too many, this is not the case. And it seems that this opioid crisis has come in 3 waves, starting in 1999 with the rise of prescription opioid overdose deaths. And in 2010, a rise in heroin overdose deaths. And then came along the synthetic, much more powerful opioids in 2013, and the overdose deaths rose considerably. So from 1999 to 2016, the amount of prescriptions of opioids quadrupled in the USA, which is quite alarming. So there has been a national response to this crisis that I'd like to talk to you quickly about, starting with the federal government with the Comprehensive Addiction and Recovery Act. This is like the first major federal addiction legislation in 40 years. And this effort was focused on prevention, treatment, recovery, legal criminal justice reform, and overdose reversal. The CDC has also been heavily involved in encouraging healthcare providers to help prevent opioid overdoses. They report a 30% increase in emergency department visits of overdose from July 2016 to September 2017. The increase was greater in adults ages 25 plus. So what they've done is they've looked at checking state prescription drug monitoring programs, providing some guidelines for prescribing opioids for chronic pain, educating patients, which is definitely something that we in the mental health field can help with. And they've also come out with an app that would help to assess treatment recommendations and alternative to opioids. Another advertisement that they have provided, looking at how it can help communities effectively respond. Again, looking at the communities and how they can help with this epidemic. And then also looking at how you can do your part to prevent opioid overdose. Looking more at the public response, creating helplines, finding out how naloxone can save lives, how to store prescription opioids securely, and learn about opioid risks. The NIH has also been involved with more of a research approach to looking at solutions, scientific solutions for non-addictive painkillers, research on long-term solutions, compounds, therapies to end this opioid addiction crisis. Another one that I pulled up that I found interesting, this is from the Arlington Community Forum. And what caught my eye was this statement down at the bottom here. Detox happens in private, but recovery happens in communities. Again, looking at the community solutions that are needed in order to truly combat the deadly disease. This one also caught my eye because it focuses on the need for evidence-based care guidelines. Providers have been floundering for quite some time as to how to address this crisis. And looking at evidence-based solutions and doing research and applying these evidence-based care guidelines has become more and more important. So the national response themes that I'd like to point out are the need for collaboration, and that addiction is a complex and yet treatable disease. And this really does call us all hands on deck. The village mentality is so important. And we also need to be very proactive to address the needs of our communities. And this is going to require evidence-based addiction treatments and assessments. So I point this out because it really does indicate just how complicated this whole process is and all the different services in our community that need to be pulled together to really address this crisis. And we at Pearson, we focus on the assessment aspects of those needs and how we believe that assessments really can help to be more efficient in order to help more people, to reduce risk, identifying risk and reducing those risks, and improving outcomes through the use of assessments. And we'll talk a little bit more about that as we go through. Because one of the most important things in assessment is that I believe there are three major areas that need to be addressed. That is the past, the present, and the future. So let's take a look at each one individually. First, in the past, has there been safety risks, safety issues in this individual's past? Risky behaviors, suicidal thoughts or attempts, and the like. Next, past trauma. Without being aware and treating past trauma, effective treatment becomes very difficult. So having evidence that there either is a potential past trauma or is a past trauma is very important. Behavioral patterns. What have they tried before? What have they done before? What has worked somewhat and what has not worked is an important piece of information to have. And the biopsychosocial history. Now, I say biopsychosocial. We typically use the term psychosocial, but it's important to add the biological aspect of it. How's their health been? Any physical difficulties that they're struggling with, whether it be chronic or just recent. But this is an important part of their recovery process and also contributes to the collaboration with other providers that are helping them. In the present, are they currently safe? Are there any safety or risk factors that are currently going on in their life? Thoughts or plans? Psychomedical factors, pain, somatic, functional complaints, especially the functional complaints, because if somebody's not functioning, it's going to be very difficult for them to recover and to fully engage in the treatment process. And the patient resources, I like to call this scaffolding. What do they have around them that can help support them when things get risk? Even treatment is not easy. Things typically get worse before they get better. So without having a good support network and without you fully understanding that support network or the lack thereof is very important for the treatment process and for a successful recovery. Emotional distress. You know, the two biggies are the depression and anxieties, of course, but also we want to encourage you to be aware of the other potential comorbid existence or some differential diagnosis such as PTSD, for example. And quality of life. This is, I think, an underutilized and an underappreciated aspect of an individual's current situation, and probably the most factor in relapse is a low quality of life. So assessing a person's quality of life is very important, and we're going to talk more about that in a little bit. And validity. Are they having full disclosure concerns? For whatever reason, they're just not able to give you a clear picture on their own. And assessments can help first identify if that is an issue, and then also help identify some factors that they may not be able to fully disclose to you at a given point in time. And for the future, planning. What's coming next? Where do they need to go next? Where do they want to go next? What's happening in their life? And how can we help them get there? Also monitoring progress. Are we reaching our target? How's their quality of life? Is there any risk factors that have now popped up? Is there any symptom replacement, which is a concept we don't talk about very often? Is that happening in this current individual? And making sure that these things aren't creeping into and creating a situation where relapse is going to be likely. So I love this quote by a past former Surgeon General. It says, "We know what works, we're just not doing enough of it." We're all being asked to do more with less. And that's a factor that's not going to go away, and it's probably going to get worse before it gets better. And so doing more with less is something that we're going to have to figure out how to accomplish. So how do we do more with less? And I love this illustration because it shows us that, to me, it illustrates how complex a human being is and how complex their culture and their life and the full picture is. And how do we plow through all this complexity and get to that core concern and get to that core need for each individual, because they are all very unique and very complex. So we need to find ways to be efficient. And efficiency comes with, one way is to expedite routine data collection. Now, don't get me wrong, I don't mean routine as benign or not important. I mean routine as these are very high quality pieces of information that we need to get to, but there are routine ways, there are ways that we can expedite the collection of that information. And so we're going to talk about that for a little while. So one of the things that Pearson has provided to do this, and that is our web-based administration scoring and reporting software called QGlobal. This allows you to administer online remotely from the patient's home. This allows you to enter raw scores from a paper pencil test and immediately get a score and a report, which is a good place to start your individualized custom report. It only gives you the basic description of what the numbers mean, then allowing you to now, expediting that part of the report, allowing you to then add the meat, the core of that report, and that's your observations, your gut instinct, your knowledge of what's going on with this individual and what they're reporting to you and what your trained instincts are telling you about them. That expediting that report building can be very freeing to do what is the most important part of your job, and that is provide treatment and interacting and building rapport with the patient. So there are several assessments that go along with what we've just talked about. Many of these are going to look very familiar to you. Others might look a little new, but I'd like to introduce them to you because they really are specifically designed for this area. And I'd like to go through each one of them real quickly for you. First is the Quick View Social History form. Now, this is complete psychosocial history and looking at 9 major areas in a limited amount of time. So getting that information, this is important information from the person's past, but it's time consuming to do face-to-face. So this is something that can be done remotely or while they're waiting for in the waiting room or after the session. This screens for social, psychological, and physical problems to aid diagnosis and treatment planning, facilitate diagnostic classification, and to clarify, and it's not just a be-all, end-all. This really, all assessments contribute to the conversation. They aren't a be-all, end-all information. Oh, I got this information, it's valuable, I'm not going to do anything with it. No. What this is to help with follow-up interviews. I hear that you're having difficulty with this or that you have in your past. Can you tell me about that? And again, this is to expedite the pathway to that conversation. So this expedited routine information is very important and very valuable, and also getting to that report. Now, you're all pretty familiar with the MMPI-2RF. Now, this aids in assessment of mental disorders. This is more on the identifying of specific problem areas and treatment planning in a variety of settings. The MMPI is used a lot in pain stimulator or spinal stimulator implants, pre-surgical evaluations, which help to ensure that we understand what are some of the psychological factors or behavioral proclivities that might aid in recovery and also that might hinder recovery. It's a very important piece of information. Evaluate participants in substance abuse programs to select appropriate treatment plan approaches. Medical patients to design effective treatment strategies, including chronic pain management, and the like. So the next one is the Millon Behavioral Medicine Diagnostic. This assesses of psychosocial factors that may support or interfere with chronic ill patient's course of treatment. Again, looking at things that are part of a person's character or personality that supports and also gets in the way of treatment. Very important pieces of information. Chronic pain norms and pain patient reports to provide professionals select suitable therapies. Pinpoint personal and social assets that may facilitate adjustment and physical limitations and lifestyle changes. You know, a lot of these individuals are really going to require a huge lifestyle change. So how to facilitate that, understand that, and help with those adjustments it's going to be a big part of their recovery program. Determine whether the patient needs more communication and support. Again, going back to that scaffolding piece that I mentioned, what additional communication, what areas of their life are they going to need to build a support network to get involved to help support their recovery? Structure post-treatment plans and self-care responsibilities. This also has been proven to help reduce healthcare costs in clinics and hospitals through reducing assessment time, more efficient triage, and decreasing complications after major procedures. It's widely used in pre-surgical evaluations as well, especially bariatric surgeries. The pain patient profile, or P3, now this assesses factors most frequently associated with chronic pain, which is going to be a large number of those that you're dealing with on a day-to-day basis. This includes depression, anxiety, somatization, and validity indices. Again, looking at whether this individual is fully disclosing what's going on in their life. Are there any secrets that they're keeping from you? And oftentimes they will be doing this in order to avoid loss of the one thing that they feel they absolutely need, and that is the substance that they're using. It is very panic-provoking to even think about not having this in their life. And so we want to make sure that we've assessed at what level are they disclosing the needed information in order to do a sufficient treatment plan and to get them on the road to recovery. Identifying the psychological roadblocks to the patient's recovery. So again, what are those things that are going to prevent them from being in a positive motion toward recovery? And assess, document, and justify the need for further psychological evaluations. So oftentimes we're being asked, this is a very quick instrument, and it takes very little time. And we're being asked to prove, why do you need to be approved for additional evaluations? Well, this is an assessment that can help you do that. Facilitate psychologist communications. Facilitate physician psychologist communications. This is that collaborative aspect that we mentioned earlier. This is very important for the medical and the psychological providers to be working together, and other professionals to be working together to build a network of help around these individuals. And then evaluate the patient's emotional readiness for surgery. Again, this is becoming a very, very important aspect and pretty much a new field for psychologists, and that is pre-surgical evaluations to make sure that this patient is ready for what's going to come next. There is going to be a change in their life. What about their psychological makeup, their character, their personality is going to be helpful in that process, and what parts may make it difficult for them? And then we can do some inoculation. We can do some pre-work to help prepare them for that situation. And easily and inexpensively measure pre- and post-treatment pain status to evaluate treatment effectiveness and monitor clinical outcomes. Again, monitoring, making sure that we're on the road to success, that we understand where the patient is at any given time, and making sure they have the tools in order to be successful. The Battery for Health Improvement 2. Now this is another one that might be new to many of you. This is one I personally really like. It helps the caregiver to shape an appropriate treatment plan that may reduce treatment time and improve patients' quality of life. This evaluates patients' readiness for medical and behavioral interventions. Again, this is an important aspect that's becoming more and more people are becoming more aware of, and that is the patient's readiness for behavioral intervention, readiness for a medical intervention, and then being able to intervene on those aspects that may prevent them from being successful after the intervention. Meet evidence-based medical treatment guidelines, outlines for good clinical practice, measurement of numerous outcomes, including reduction in pain, most importantly, the improvement of functioning and their satisfaction with their care. Very important pieces of information. And measure the relationship and impact of physical, environmental, and psychological factors on the patient's treatment. So what are those things that are going to affect their treatment in the physical, environmental, and the psychological factors? And validity scales. There are two on this instrument called self-disclosure and defensiveness. And facilitate the communication with the multidisciplinary team. Again, going back to this community, this is a village mentality that we need to. And this instrument is very good at helping to facilitate that communication so that everybody is speaking a very similar language and a very similar understanding of what's going on with this individual. The BBHI2 is the brief battery of health improvement. So if time is a factor, this is a briefer version of that same test. Again, measuring many of the exact same features, looking at social factors that can impact the response to normal course of treatment and recovery. Again, measuring depression and anxiety and somatic complaints. It only has one validity scale, and that's defensiveness. Again, to help understand or at least get a taste for how honest and how forthright this individual is being with you. Last but definitely not least is the quality of life inventory. Now this is again one of those areas I don't think we measure or talk about enough. And this is the positive psychology side of things and is well suited for planning, evaluating, and tracking medical and psychological treatments. This is it also can be very motivating and help to build that blueprint for a balanced drug-free lifestyle. Again, going back to that concept that change is going to happen in these people's lives. And so looking at having a positive perspective and looking at quality of life and what that drug-free lifestyle would look like is an important conversation, and the quality of life inventory contributes greatly to that. This measures assets, strengths, and problems in a non-pathological way. We look at, okay, where's the pathology, but also where's the quality in this person's life? What are the strengths that we can build on, and maybe even some weaknesses in their quality of life that we need to make sure we pay attention to. Parts of their quality of life that have not been going well. And also, this is a great measure for treatment outcomes, because the bottom line, like I've said before, quality of life is probably the lack thereof is probably one of the biggest causes of relapse there is. And so by measuring their quality of life, we can have an idea of just how big of risk they're at, or if that quality of life is improving. So that's all I have for today. Thank you for joining me. For more information, please check us out at pearsonassessments.com. My email address is at the bottom. Feel free to contact me directly if you need help with selecting assessments, understanding assessments, or would just like to brainstorm. And if you're at APA or any of the other conferences throughout the year, please come by the booth and say hi. I would love to shake your hand and thank you for your work in the community. Thank you very much. Have a great day.